Good afternoon, everyone. On behalf of the Ontario Public Health Association, I'm pleased to welcome you to today's webinar. My name is Kelvin Lama, and I'm a coordinator at OPHA. The webinar being presented today is in partnership with the Leading Edge Group, and we will be speaking about Lean Six Sigma for public health. Before we get started, there are a few housekeeping details that I would like to share. This webinar will be recorded, and you can find it on OPHA's YouTube channel within 2 weeks. We will also follow up with an email once this is live. A PDF of each presented slide deck and resources are available on the Files pod. Please click to download for your own copy. The format for today's webinar will be as follows. We will have 2 15-minute presentations from previous Greenbelt participants on their quality improvement projects, followed with a 10 to 15-minute question-answer period depending on the time we have. If you have any questions throughout the presentations, please type them in the chat box below. We will address as many questions as time allows in the question-answer period following our presentation. If there are any unanswered questions, we will provide answers in a follow-up email within 2 weeks of this webinar. Before we start our presentation, I would like to start with 2 poll questions. Good to see that most of the people attending today have taken a workshop and are interested in our workshops as well. Thank you for participating in the poll. Now for the second poll. Okay, thank you again for participating. Okay, so now that we've done a few poll questions to sort of gauge who our audience is, I would like to begin. Ontario Public Health Association was founded in 1949 by a group of doctors who wanted to see an increased emphasis on preventative medicine. As a charity, we have continued to honor this purpose through our vision, which prioritizes working together to achieve optimal health for all. Since being founded by doctors, our membership base has broadened to include a diverse base of members. Our mission of providing thought leadership has evolved over time to reflect the breadth of public health, from health promotion, health protection, to prevention work in Ontario, as well as strengthening the impact of those who are active in public and community health. As I mentioned earlier, we are hosting this webinar in partnership with the Leading Edge Group. So now I would like to hand it over to Chris Chadwick from the Leading Edge Group to speak about their organization and to begin the presentation for today.
Thank you. It's a pleasure to be here and joining and working along with this group today. I am here representing the Leading Edge Group. As you can see there, it was established in 1995. And we are a global company with offices over 3 different continents. We have an office in Canada, in Toronto, Ireland, Australia. Current clients that we service are very vast, including public health, community-based health, social service groups, family health teams, healthcare, government, food, retail, construction, and manufacturing. So it's a very, as you can see on there, it's a very, very broad group that we're able to serve and work with. The type of work that we provide and the type of services that we provide is training, certification on training such as yellow belt, white belt, yellow belt, green, and black belt. We do provide some leadership management and staff training as well, and we also provide some training in regards to various tools and techniques to help organizations to either utilize lean principles or to take it to a next step. We also do have a consulting element to the services that we provide. They can be point projects where we come in and work on specific improvement projects. It can be also help with a more a strategic vision and roadmap development, help people with achieve the vision, and end-to-end transformation. So that could be for any for a more mature organization, or it can also be for a lean startup. And then finally, we do have a service using technology, a cloud-based continuous improvement solution called Cube, which has a number of features in it that allow us to, an organization to share the projects that are happening across their organization, maybe as in a multi-site organization, such as yourselves are able to share the projects across a continuum of people, and also track the status of the projects and potentially even the return on investment, where the project's at, the value or improvements. Finally, just a very brief introduction of myself. As you see, my name there is Chris Chadwick. I've been working using in the continuous quality improvement world for 20 years, with a lot of experience in using the Six Sigma and lean methodologies. I have been working for a number of years in the healthcare sector and working along with public health teams and mentoring a number of different green and black belt through their certification, as well as continuing to practice a number of different partners and clients in the public health as well as healthcare sectors. So with that, that's just a very quick and brief introduction to myself. What I am excited to be able to do today is to introduce Leah, who is a quality improvement specialist with Toronto Public Health, who is going to take us through her project, and I will come back in and introduce the next presenter after that. So I would like to turn it over to Leah now.
So hello, thank you, Chris, for that introduction. I just want to give a thank you to OPHA and Leading Edge for inviting me to share my Greenbelt project today. I completed it in spring of 2018. And as the slide describes, the name of the project is Improving Customer Flow Throughout VPD's Immunization Clinics for Students. So VPD refers to our Vaccine Preventable Diseases program within Toronto Public Health. So just my background quickly is I started as a nurse, then I did some health promotion, and I'm working as a quality improvement specialist at Toronto Public Health. And this is the context in which I did my project. And so I'm going to share in that context the application of lean principles that we did through our vaccine program. So before I go into the project, I want to give a big shout out to the project work group who were instrumental to its success. It was a mixed group. We had the subject matter experts of our team, and then there was management and myself as the specialist. So I'm actually honored to be able to share highlights on behalf of the team with you today. So to give some context to the program area, the clinics that we were targeting had to do with students' immunizations that were occurring in the community. So these weren't the ones that were happening in school, but the ones that are happening at 3 different sites across the city of Toronto. Also in these 3 different sites, they were staffed by a mix of different teams in these different sites. And another thing to note is that these clinics are becoming increasingly busier each year as we go. So we currently see 300 students in our clinics, but the demand and stress on our staff continues to grow. So the problem we really wanted to solve when we decided this was our project was to improve the time it took for our customers, who happen to be students and students with parents, to navigate through these community-based immunization clinics for students. So why did we choose this project for a Lean Six Sigma? Well, there were multiple elements that lended itself well. So first of all, there was this element of the clinics were becoming increasingly busy, and we knew that there was a piece that had to do with flow, where we could increase the efficiency of these clinics. Secondly, we wanted to understand what the customers were experiencing and to improve the clinics from their perspective specifically. Then we talked about the increased stress and demand that was on staff, and there was this idea that through eliminating waste, we could hopefully have some more organized clinics that might make these clinics less chaotic and ease those demands on our staff. And then finally, there was an element of variation that happened within each clinic location, as well as across each clinic. So we wanted to try to standardize the process for our staff. So to walk you through the project, I'm going to use a DMAIC approach, which is a Six Sigma methodology of problem solving. We didn't strictly use this method when we did the project. We did a lot more lean with our project, but I found it very helpful to explain what we did. I've also highlighted some new tools that we use that are Lean Six Sigma tools. I won't be going through each one of them, but I will be talking about specific ones that are the high level for the project. So we'll start with define, which is to the left of your screen. And in this point, we defined the team, their roles, the project goals, but really we defined what we wanted to know what the customers wanted and valued. And to do this, we did an activity called the Voice of the Customer, where we went to Gamba. So I went to the actual clinics and spoke to students and their parents about what they valued in our clinic. And a number of things came out, but one of the biggest elements was that parents and students expected to wait and spend time in the clinic, but there was a threshold of what they were willing to wait. So 60 minutes, so 1 hour, was kind of the benchmark of where they expected to wait at our clinic. So taking this information, we did some baseline measurements of from start to finish, clients going through our clinic, and we did some intervals as well, and found that only 43% of those who went through our baseline clinic were seen within 60 minutes. So we were really underperforming in what our customers expected of us to begin with. So that actually ended up being rolled into our SMART objective, which I will mention a little bit further on. So in the measurement phase, I mean, we did a baseline measurement, but what we also needed to look at is what is currently happening at these clinics. How does the process work? So that is what we refer to as the as-is process. And we used a value stream mapping tool that was really important to be able to do before we thought about the to-be or what we wanted the improvement to look like. So this next slide is a picture of what I call the raw post-it version of our value stream map. And this happened with the work group members that I had showed earlier on the slide. So we went through and mapped everything out. There's a full process that we went through. So the next part is we need to be able to analyze that value stream map. And I actually found it much more helpful to analyze it from a digital format. So I converted the post-it format into a digital format, which lended us turn into this slide. So I appreciate that the slide is actually really small, or the map is small, but I'm going to walk you through the important pieces that I've highlighted. So no need to have to worry about reading the actual process map or the value stream map. But I'm going to start with the purple boxes at the bottom. And what that box indicates is what you go through each of the micro steps, so all the steps in the process, and you give a value to, you systematically give a value to that item. So you decide if it's non-value added, necessary non-value added, or value added. So and this gives us an easy way to quantify where there's waste in the process. So if you see in the purple box at the top, there's a blue box that says NVA, that's the non-value added. We identified 10 out of the 51 steps altogether that we thought were non-value added, which equates to 20% of the process. And so just one thing to note is that a lot of the blue, so the non-value added, is at the beginning column, which was the registration phase, which was important to when we targeted our change ideas. A lot of it actually happened there because that's where we saw a lot of the waste. The next box is the orange box to the right. And what this tells us, it's a cumulative time of the macro and micro steps and their respective wait times. So this gives us the lead time of the process. So the lead time tells us, what's the best case and worst case scenario for our process. Well, at best, we estimated that we could get through the clinic a customer could get through in 30 minutes. At worst, it was 140 minutes, which is roughly 2.5 hours. So that's a huge variation between 30 minutes and 2.5 hours. And for some people that might be shocking and alarming and scary, but for those quality-minded, it gives an exciting opportunity for improvement. So that's exactly what we did to try to bring down that variation. So our ultimate aim was to serve at least 80% of our customers in these clinics in less than 60 minutes by mid-April 2018. And just a note to say, we chose 80% because we wanted to focus on the majority. We knew that there were some outliers, and so we just wanted to focus on the majority as the first time around. So now we get to the exciting part where we got to brainstorm and get solutions. And so before that, we kind of looked at the value stream map and looked for roadblocks and bottlenecks. We did a lot of brainstorming, using some change ideas and change concepts, specifically the lean ones that I had learned in the training. And not surprisingly, we came up with a lot of ideas. Actually, so much so that we needed to find a way to pare it down to make it more reasonable. So we did some prioritization of the ideas, looking at what was in our control, what happened across all 3 clinics, and what was worth solving for the ultimate goal. So with this, we created a 2B process map, we created an action plan matrix, a communication plan, and then we implemented. And we implemented over 6 pilot clinics, so meaning that there were 2 clinics per location or clinic site. So this slide just shows an overview of some of the change ideas. This is a specific lean principle of visual management. So the photo on the left shows a number 1. Those big number, it was signs from number 1 to number 4. It was a directional sign to be able to say to clients where they should go next. So some customers didn't need to go to step 2, they could go to 3. So instead of saying, when they're at step 1 is the check-in, and instead of saying, go through the double doors and your second door on the right, there's going to be a line and someone will help you there, we could say go to line up at number 3, which was much more clear. There was also a sign that indicated what we were currently serving, the appointment time that we were currently serving. And we also then highlighted the consent form to indicate which section the parent or student needs to complete it on their own versus the section that needed to be done with the nurse. So this slide just highlights the high-level results of our project. There were actually many other data points that we analyzed, but the figure on the left indicates what our voice of the customer feedback came back, talking about the 60-minute mark. So, what were the clients being served in less than 60 minutes? As you can see on the left, the baseline was 43%. Then we have the 6 clinics. Our pilot clinics, and all of them we were able to reach 80% of our clients being seen under 6 minutes. Sorry, 5 of them we were able to. The 1 clinic that did not reach, we were still pretty happy with that result because it was still much closer to the target than it was to our baseline. The second figure indicates the average time it took for customers to navigate through our clinic. And as you can see by this line graph, the baseline, it took on average 1 hour and 8 minutes. During our pilot clinics, it ranged from 22 minutes to 55 minutes. So we were really happy with that result because it was under our 1 hour goal. So the next phase in the DMAIC approach is control. So in the control phase, we reviewed all the quantitative and qualitative data. The qualitative data was both from our customers and from our staff. We then debriefed as a work group to decide, are we going to adopt, adapt, or abandon each change idea? And then from that, those adopted and adapted were rolled into our procedure that was then a form of standardizing the process. And these were shared, the procedure was shared with our staff along with the results. But most importantly to this phase, for me particularly, was to celebrate the staff, not just their success in the project, but really their commitment. Because either way, whatever happened with this project, they had committed a lot of their time and energy into seeing these improvements and pilot tests. So what's happening now? The next steps are really about sustainment. So this project happened just over a year ago, and so now we've made a commitment for this fall to repeat the time trials to see if we are sustaining and maintaining our SMART objectives. So I look forward to seeing the results of this fall. And then finally, we have the lessons learned. I mean, the first thing is that we were able to learn about new lean tools and put them into practice so that we can pull from them for future use. There was this idea of the success of focusing on shared goals, which we know it's, in human nature when there's change, we can often think about how it's going to impact us in our specific role. But having the shared focus being a customer perspective really grounded us as we went through the project to focus on this shared goal of customer perspective. The next point has to do with challenging scope creep. I mean, when you have a momentum of great ideas happening, it's hard to then put a pinpoint of stopping some ideas from happening. But you need to be able to put some parameters on where to start and hold. So what I'd say is with that is just, maintain the parameters and keep sending things on parking lots, but try to make sure that you keep it in scope to be able to finish it on time. The feasible time frame is just a concept, of just making sure they have some wiggle room. Things often take a little longer than anticipated, so putting that into any project that you're planning. And the last item is a value of staff engagement. And this is just, we know when there's change causes anxiety of the unknown. And, when staff are involved, first of all, they're the subject matter experts, so it makes sense for them to be involved. But also, because they're helping to decide the process, that unknown isn't there because they're helping to guide it. And there's a sense of ownership of the improvement and the solutions that we noted, and you see this interest and investment in improving the clinics, because both from the customer's perspective and theirs, because these were pretty busy clinics. But the greatest part about this success of this project has been seen after this project was finished. This team in particular do continuous quality improvement. They embody it. They take ideas, they test it, and they continuously try to improve these clinics even after this project. So that's basically a high level of our project. I really enjoyed working with the staff on this and using some new tools that I learned through my training with Lean Six Sigma and Leading Edge and OPHA collaboration. Just thank you all for joining and hearing about it, and I'm happy to answer questions when we get to that section of today's presentation.
Thank you, Leah. It's a great presentation. So I am going to now introduce Laurencia, who is an acting supervisor at the Regional Municipality of York, and she is going to present her presentation to us as well. Thank you very much.
Good afternoon. That was a great presentation, Leah. Similar to Leah, I just want to start off by thanking OPHA and Leading Edge Group My main belt project focused on service case comments entry within a 24-hour period. And I just want to start off by briefly introducing myself. I've had the privilege of being a public health inspector in York Region for the past 12 years, and at that time I've had the privilege of being in a couple of various roles. And in particular, this Green Belt project was done when I was in the role as an acting team. So just a brief background on the project. In health protection at York Region, we use CHIP, which is a cloud-based system for our inspections and our investigations. And within CHIPS, we use service cases, which helps us to keep track of our complaints, our inquiries, and all other actions that we take in relation to any investigation or complaint. We also have an admin policy as it relates to documentation for service cases that requires that notes and attachments are complete as possible and entered within 24 hours to the date that an action has been taken. And the rationale for this project was basically to ensure that staff were entering notes and attachments within the 24 time period as stated. As it relates to the business that we do here for York Region, we have a high level or high amount of service cases coming in and being actioned on a daily and monthly basis. So it is important that any action taken is recorded in a timely manner to avoid confusion and or backlog. Should there be any legal action taken relating to a particular investigation, the service cases would be used. And so it becomes important that all notes are inputted into the service case to record details of actions, to track evidence, and to aid in refreshing the PHI's memory. At the same time, should a freedom of information request come in, it poses a risk to our reputation if notes are not entered in a timely fashion. So at this is more of a pictorial representation of the actions that I took. And the following slide, I'm just going to go into a little bit more detail in terms of how the project went about. So as it relates to the approach taken, first off, as I had mentioned, I was an acting team lead at the time that I did the project last year. And so spoke to my manager, and who was at the time manager of the public health practice team. Now in York Region, the public health practice team deals mainly with CQI. So I spoke to her, I got her buy-in, and then I put out a call out for staff members to basically represent each program that we have. And I did this because we have a lot of inspectors, but at the same time, I wanted to make sure that as it relates to service case documentation, that I had a great representative or representation from each of the programs. And then once that was done, I went about selecting the tools that I would use. So the first tool that I used was the process map. And the process map that was created from the volunteers of 8 health inspectors basically showed how our Health Connection staff receive the initial complaints from the public. They create the service case in CHIPS, which is then forwarded to the appropriate area PHI, who will then action the call. And while they're actioning the call, they document all the actions that they take. Once the service case is completed, it is then sent to the manager to be reviewed and closed or closed by the area PHI, depending if it's an inquiry or concern. The fishbone diagram was also used to determine the cause of service case entry being greater than 24 hours. And based on the fishbone diagram, a couple of the themes that came out was that the policy and procedures were not clear. PHIs at times were performing batch entries as opposed to a single flow. So they would maybe in a week, they may get 10 or 12 service cases, and instead of putting the service case notes in once they're done in action, they wait until the end of the week or the end of the following week, sit down and enter their notes in. PHIs were also intimidated to enter and submit the notes. The way service cases worked is once you submitted a note, you couldn't go back to edit it. The documentation format that was required of them was not clear, and PHIs also had a tendency to hold off writing notes for complicated service cases. So another tool we used was the brainstorming tool. So at the first of the first session, the 8 participants were provided with colored Post-it notes, and The idea was to have one idea per Post-it note, and they were asked to write out any and as many solutions as they could come up with in terms of how to solve the issue. And the recurring theme that kept coming up was that the policies and procedures needed to be clear and more defined. And the last tool that was used was the failure modes and effects analysis. And the largest RPN, when we went through the whole process, basically dealt with recommendations dealing with documentation in the Black Book. So we have our Black Book that staff have to record in, as well as our service case notes that staff had to do. So there was just a lot of competing issues right there. So what I did next then was that I took a report of service cases from January 1st of 2018 to March 1st of 2018. And it might look like it's a short time period, but the rationale for this is that a service case alone, one service case alone, may have upwards of 10 case comments. And so the data was analyzed in two ways. The first form of analysis, the data was exported into an Excel spreadsheet. It was manually manipulated to ensure that the dates entered in the case comment by the PHI was in the same format as that at the timestamp by the program Salesforce. And so from here, a pivot table was created to show the number of service cases that were entered within 24 hours or past 24 hours. So of the almost 10,000 case comments, 80% were entered within a 24-hour period, but 13% were entered 2 or more days after the action had taken place. The second set of analysis that was done on that data was to count by looking at the PHI. Each PHI was given like a code, and then to determine if there were outliers, if it was just a particular group of PHIs that were entering service case notes past 24 hours, or if it was consistent across the board. And the data showed that this was a persistent problem across the board. So as a result of the tools used, specific improvement recommendations were made. The first was that there needed to be clear policies and procedures for service cases. Currently, as it stood when the project was being done, it was not clear. So the first recommendation was that policies and procedures needed to be clear in terms of what needed to be documented. And that took away from any guessing games that staff felt. The second was to have an enforcement training, specifically related to documentation in the legal Black Book. Staff wanted training focused on how to document inspections where enforcement actions were taken. This training should provide clear examples of circumstances of when PHIs are required to document in their Black Book as opposed to when they don't have to. And the third recommendation was that following the revision of the service case policy and procedure and the enforcement training, it was to have a risk session. So we call it refresh, inspire, and train. That's our training session here in our department. And basically, staff wanted, amongst other things, training that would really address the entry of service case comments specific to the date, the time, the task taken, and the information that needed to be entered to basically sum up the entire case. So at the conclusion of my green belt in December 2018, health protection was in the process of transitioning off our current platform at that time onto a new platform. So a lot of the recommendations, actually all of the recommendations provided had to wait. But since then, we have had a lot of changes. To date, the policies and procedures for service cases has been amended to provide greater clarity for staff. It provides information in terms of what needs to be documented and how, and it has provided staff with naming conventions for attachments, so there's no guessing game. At the same time, the Public Health Branch Documentation Standard was created, and it has been rolled out to all staff. The documentation provides clear expectations of documentation requirements for all Public Health Branch staff. And in it also, there's a list of approved abbreviations, acronyms, and symbols. To date, the enforcement training and risk sessions are in the works. The senior for the enforcement program is in the process of meeting with all other program seniors to get that RIT training ready to be provided to staff. In terms of lessons learned, one of the first things I noticed was that the scope of the project at the beginning seemed small, and so because of that, I went in with a lot of preconceived notions in terms of what the answer would be, and I found out that this was not the case. During discussions with participants in the focus groups that I had, we had 4, it was really challenging to keep them on track, and I found that one of the things that really helped was having experience in facilitated discussions. So I would suggest that if you're ever doing a lean project, just to make sure that you have some background in terms of facilitating discussions with people. And while there were various tools that we learned throughout the course, experience and practice is required to be able to pick the right tools from the onset. And at the same time, doing a lean project is hard, and especially with me, I had to do this at the side of my desk in addition to all of my other work. And it does require you to begin from scratch and to really embrace the entire process. And understanding that, you know what, you may fail, but that's fine. You just, you find a way, just keep trying. And in the end, not being afraid to try. So that's all that I have.
So thank you very much, Laurencia. That was very very good and very interesting to review again. I have had the pleasure of being able to review these. I was a mentor for both of these students. So I added one thing, Laurencia, into the chat box, and I'm just going to explain this maybe while, if there are any other questions that are out there, please put them into the chat box, and we will try to, I will direct them. The note that I put down into the chat box, you had mentioned that you're looking for the largest RPN, which I just added in there, clarity. When we think about acronyms, that's a risk priority number, which that term may be very familiar to some and may not be to others. And the FMEA is actually something that originated out of the aviation industry and has had a lot of good success in when used in healthcare as well. So that was very good. I do encourage anyone to go in and put in some any questions that you might have. If I could, I'm just going to go back a very quick summary while people are typing in. But both Leah and Laurencia both had a common theme that I found to be very interesting, which is focusing on the lean principle of flow. And that is excellent to see that lean principle was evident in both, and that you both in different ways have addressed the importance of using the DMAIC model, following up through the control phase, that final phase, and in yours, Laurencia, making sure that this project is delivered, and then how do we know, and you're doing that in a structured way. There are different lean tools that we can utilize, such as the Japanese term is kamishibai, but a very simple quality check to make sure it's being integrated. So excellent work. So there's a very, very good question here, which is how do you avoid blame when doing failure mode effect analysis? For instance, since you did an FMEA, would you feel comfortable to answer that?
I can try. I think for us, it was really just sticking to the process. So when you do the failure mode analysis, the sheet, you have the process or product name, and then you have who's responsible. So right off the bat, and from the process map, you already know that the bulk of the work, for us anyway, as relates to service cases, lies with the health inspector. And it's not so much as saying, well, you didn't answer it or you didn't put your thing in, your notes in. It's just really looking at the process and understanding that the main goal that you're trying to reach is consistency, things being entered in a timely manner. So we're not looking at what we've done wrong in the past, so to speak, and who's done what's wrong. We're looking at how we can learn from the past and move towards a better future where we're all consistent and we're entering things in a timely manner. So I think this is where I was talking about having experience and facilitated discussion, just really making sure that you're always bringing people back to what the goal and the end game is, and just keeping it clear and in the forefront so that when you do have those sidebar conversations happening, you're able to just bring people back to the discussion at hand.
Okay. Leah, I don't know if you would have anything. I know you did not use an FMEA, but if you would want to add anything in there, I think, well, I'll just turn it to you and see if you did want to add anything. If not, I will just add a closing thought.
Well, I would just, I mean, for me, failure came in just in terms of the whole project. You know, when we talk about quality, we don't know that what we're going to do is going to, are we going to make things worse or make things better, or are there going to be unintended things that happen that cause even more chaos? So apart from the very strict FMEA failure discussion, there's also just failure with any quality project, which we know. And so that's one of the things that when I talked about celebrating, it's not that I just wanted to celebrate with the staff that we had success, because it could be that we had failure, like this project didn't succeed in the big term, but that really we focus on the staff commitment no matter what happens with these projects, because they put a lot of time and effort into them. So that was failure for me, came in that perspective with my project.
Okay. There's a couple things I'd like to just quickly talk to then, if I could. First of all, I want to go back to one of the key principles of Lean is respect for people, and both students exhibited that through their team collaboration and engagement, and really focusing on the process. So I think that addresses a little bit of what I'd want to say there. There's this mantra that we will often say, which is we are hard on the process, soft on the people. And what we're really meaning there is there's a belief of 95, it's a 95-5 type of a rule, where 95% of problems exist as a result of the process and not of the people. Very, very few people go out and deliberately cause, and I believe it's even less than that, that 5%. The second point that I would like to the second point that I'd like to go back to, because both Laurencia and Leah referenced this, Leah more recently, through the trials we fear failure, that we're going to try an experiment. We have hypotheses. If we do this, something will change to the better. And when it doesn't, we kind of consider that to be a failure. But we actually learned something from it, and it was actually we could spin it that it's a positive. We've learned that trying this does not impact that, and so it's not a failure. I've been doing this for 20 years, and I still we have to remind ourselves of that. But every trial will give us information, and it's being brave to take that first step, as both Laurencia and Leah have experienced. So I do want to really, and there's people who have ever taken the the yellow belt or green belt or have listened to me will often hear the same story. So I apologize for anyone that is hearing this for a second or third time. But when we think about a product that you might use in your home called WD-40, well, there's a reason it's WD-40 and it's not WD-1. It took them 40 iterations to get that right recipe or balance together, that right the right ingredients to make that product safe for our use and effective for our use. So experiments often do take more than one try. So very, very important thing to remember. We learn from our experiences. there was one question that was in here, and maybe I can turn this back to both students just talked about, but there was a request to explain the Lean Sigma belts in relation to both projects. Both Laurencia and Leah did their green belt. Lean does have, and Six Sigma has a series of belts. Quite often, a very, very introductory level is white belt, but there is also yellow belt. Green belt gets a bit more detailed to the level where these projects use some of the tools that would be introduced there. And then black belt is, more in-depth program, and actually I'm speaking ahead a little bit because I know that does come up into our wrap-up slide here. But Leah and Laurencia, if you would want to comment about your experience, I don't know if you did do the yellow before you did green, but what that experience was like, if you could.
Okay. This is,
Go ahead, Leah.
Go ahead. We're both being too polite. Thank you. I guess, so I had done both yellow and green before, yellow and white before doing green. For me, the biggest value of doing green was actually having the project piece, because it's one thing to learn about something in class, but doing something with a project that is sort of personal was really the value of the green belt for me, so that now I really understand these concepts of lean. I mean, I was doing quality improvement before without having training in lean, so root cause analysis weren't new or change ideas weren't new, but the strategy behind lean and thinking about variation and flow, it gives a framework to think about quality improvement in a way that it's something you can pull from, in ways to help different projects. So that to me was what, the relation to the project was I was able to not just do a process map, but do a value stream map, which I'd never done before. And it offered pieces of information to the project that I wouldn't have known to analyze or have maybe had an easy way to analyze without having done the value stream map. So that was kind of the greatest part for me, was putting things into practice.
I have to agree with Leah. I too had the white and yellow belts before I did my green, and there was a lot of theory in the two previous courses, and in the green you actually get to put it in practice, and that's why I said in my last slide that it is a lot of hard work, because it's one thing to know the theory, and then it's another thing to apply it, and it does give a lot more value, I find, to what we do, and especially when I look at service cases and the progress we've made as a result of this Green Belt project. But I would recommend that if you haven't taken any of the lean courses before, to definitely start with the white and yellow, because it gives you a lot more of a foundational basis to start. And there are a lot of tools that you learn about, but for me, it was just really understanding what it is that I wanted to get from this project in order to be able to select the right tool. And so, yeah, the yellow really did help in leading me to the green.
Thank you. So, and I will add just as a black belt, where the black takes you to is just getting more expert experience, which really comes from repetitions that had been recommended earlier from Paulette and Leah. The more you do, the more you get comfort with. And the black also continues a significant part of helping teams through change is being able to, you're taking on more complex projects, so then that's the importance of project management and change management, which is integrated as part of all the various information that you get with the black. So it's integrating strategic planning, project management, change management, and of course more advanced lean tools. So that just kind of covers the various layers of the belt. So I am not seeing, there was one request that I will turn back to our moderator because it's in regards to sharing a link for the FMEA model. If there are other questions that do come up, they will be followed up. I believe that was covered at the beginning with within 2 weeks. But with that, I think I will turn it back to the OPHA host who can take close this off. There are no other pending questions I'm seeing in the chat box.
Thank you, Chris. So I just wanted to say thank you again to our presenters, Leah and Laurentia, for taking the time to share your project with us today. Thank you to the Leading Edge team members, Chris and Emily, for facilitating this webinar and making it possible. I would like to end the webinar today by letting our participants know that we actually do have a white and yellow belt coming up in October. The dates and the links are in the file pod in the presentation as well, and it will be held in Toronto. We are also doing our black belt from November 20th to 22. Black belt workshops are usually 3 days long. So with that, I invite you guys to connect with us with OPHA and with Leading Edge. And we will, like I mentioned again, send a follow-up email with the questions and the answers as well as the links when it is available. Thank you for attending today's webinar.